Okay, let's get after ALS Airway. As I said, if you're looking for this somewhere on your website, it's not going to be there, but I will upload this for you. Like I said, I have a few slides on here we want to talk about. A laryngectomy is going to be it's a surgical procedure where the larynx has been removed. What is the larynx? Anybody? It's what? The larynx is what? The vocal cords, yeah, the voice box. So those have been removed. So what do the vocal cords do for us? They allow us to make sound. They allow us to talk. So if those are removed, what they're going to do is they're going to leave an opening in the front of the neck here for the patient to breathe. So you're going to be looking for that. A tracheostomy is the procedure that actually forms the stoma. You'll find that patients that have a stoma usually want to cover that up. Have you ever seen one on a patient? You know, you're just like at the mall or something, you look down and they have this like giant hole. What do you usually do? God, look at that hole in his gut. Yeah, so they usually cover that up, so I might be covering one up right now, right? Could I be? Yeah. Actually, if they have a temporary one, and that is not uncommon either, where they may have a stoma, but they also can breathe through their mouth and nose. And you can see that that could create a problem for you, right? You start bagging a patient and the chest doesn't rise. You're bagging a patient, the chest doesn't rise. What's the first thing you're going to do? Reposition the head, yeah. Now if it's still, you know you've got the airway open and you still don't see any chest rise, but you're pumping that bag and that air's going somewhere, what's the next thing you're going to check? Yeah, that air's going somewhere, unless you can tell you don't have a good mask seal. So reposition the airway, check your mask seal, and then check see if they might have a stoma. Now, if they've got a temporary stoma, so they're breathing here and they're breathing through the mouth and nose, what are you going to do? Call your friend, call me, call your friend, what? What are you going to do? Panic? What? Yeah, you got to plug one or the other. You either got to close the mouth and the nose, seal that off, or you're going to have to seal the stoma. Which one's going to be easier to do? Probably the stoma, yeah. So you'll have to do that. But don't forget to look for those. Okay. All right, covered that. Good job for me. Now, patients that have a stoma, one of the problems they have is they have difficulty clearing the mucus out of their lungs. Just by virtue of they're not breathing through their mouth and nose. And what's one of the main things that the nose does for us besides, you know, warm and it cleans it. So stuff actually gets into their lungs that if they were breathing through their nose, it wouldn't get that far. So they create a lot of mucus, and as they try to move that up, it's very thick. You know, it hasn't been really humidified as it came in. It hasn't been cleared, so it gets very thick, and they have difficulty getting rid of that. So one of the things you're going to do very frequently, and it's a frequent reason for calls from these types of patients, is they've gotten a mucus plug in there and they can't get out. So the way we're going to manage that is, the best way is going to be to instill a little bit of fluid, say 2 or 3 cc's of fluid, just with a little naked syringe, just pour some fluid in there, and then you can start suctioning. That tends to break that up. You're going to suction with what type of suction catheter? Yeah, it's going to be a French. How far are you going to put that in? You're not going to do it too far. You know, unless you're doing, you know, bronchial suctioning, you don't need it that long, but probably a couple of inches should do you without a problem, and suction that out. It says, of course, limit your suctioning to 10 seconds, because when you're suctioning this area, you're actually sucking the air right out of their lungs. It's very uncomfortable for them. So 10 seconds might be on the long side for these poor people. On these slides, some of them you'll see it says skill drill 1514. That means in your textbook, there's a description of how to do this that might be better for you if you're a reader-writer, which I am. Okay, ventilating the stoma patient. On a regular patient, how do we open the airway if it's a medical patient? Head tilt, chin lift. Do we need to do that with a stoma patient? No, we don't have any airway issues, so the best way to manage them is going to be just with their head neutral. You don't need to tip it back, you don't need a jaw thrust, all that stuff is great. Now, when you're trying to provide just a high flow oxygen, you don't want to put a large face mask there, but you can put a child face mask over that to facilitate that. Yeah. Infant or child size, whatever you need. With a stoma patient, you may need to use 2 people when you're using that bag valve mask. You're not using the mask if you're ventilating a stoma patient, because most of the time, these patients are pretty ill. They're going to have a tube in there already. And there are different kinds of ones. The ones I've seen most commonly are called the Shiley, and it's already set. It's kind of like the end of your ET tubes, which we'll look at in a little bit. But you just attach your bag there, and then you bag that way. If you have a patient, say, that has, they breathe through their mouth and nose as well as the stoma, then you're either going to, as I've said, have somebody close off the mouth and nose, or somebody close the stoma. If you're doing a bag valve mask and they don't have a little Shiley or a little tube already, it's probably going to be easier to ventilate through their mouth and nose. Otherwise, do it through the stoma. Questions about that? Okay. This is an example of, this really looks like an ET tube. And you can make one of these yourself. If you have to put a tube in, like an intubation, you would probably cut that off and slide that in. Because you don't, if you put a long ET tube in from here, where's that end going to end up? I hope not. Who said stomach? Hope you failed the test today. Yeah, if you put that whole tube in here, if you put that whole tube in here, where's it going to end up? Yeah, which is it going to go to? It's going to go on the right side, right? Why does it go on the right side? Yeah, less of a bend, so it's going to go in the right rather than the left, and you don't want that. So you may have to cut that off if that's what you're trying to do here. And a lot of times, it's going to be you making a decision of the best way you can manage this airway. It's not going to be, I've told you you have to do it like this every time. You're going to have to be creative sometimes in managing this. Okay, what else? I already mentioned about the secretions. Oftentimes your stoma patients, they'll have an acute respiratory distress period or sudden dyspnea, and it's going to be from thick secretions. So they just need somebody to help them suction that out. All right. Okay, y'all ready? I covered that old stuff pretty quick. Advanced airway management. This is what you've been waiting on, right? Yeah. This is going to be probably, airway is going to be your most important skill that you learn, and this goes much beyond skill, because you're going to have to do a lot of critical thinking as you make decisions about how you're going to manage a patient's airway. Today we're going to be looking specifically at the times when you've made the decision to go forward with an advanced airway. Now, I don't think we talk so much about the dual lumen airways here. I think, if I can remember, we're just doing the intubations. Oral nasal intubations. Okay, endotracheal intubation is going to be your preferred method of controlling your patient's airway. It's like the gold standard or something. It's the only definitive way that you know you can manage your patient's airway, provided you've done it correctly and you've done a good assessment so you know you're in the right place. Okay, I said at this point you already decided if you were going to intubate or not. Well, not really. I have a list here of some things that you're going to consider when you're trying to make the decision of whether you're going to move forward with intubation or not. I know you can't see it there. I'm so sorry. If the patient, of course, is in respiratory arrest or cardiac arrest, you absolutely want to move forward with intubation. If they're unconscious, just because they're unconscious doesn't mean you have a green pass to intubate them. There has to be something else going on. If the patient is breathing well, they've got good rate, good quality, good depth, just because they're unconscious doesn't mean that's an opportunity for you to intubate. I mean, I could look out here, and some of you patients, you guys look like you're unconscious now, and your classmates would love to practice intubation. If you feel like there's a real risk of aspiration for your patient, say they're unconscious, but they've been vomiting. You know, if they've had a stroke, they increase the risk of vomiting, then yeah, you want to seriously look at intubating the patient. If you have some type of obstruction in a foreign body, or if you've got a lot of swelling in the airway, like from anaphylaxis or a lot of edema or burns, for instance, then you want to seriously consider intubating them. If you can get a tube in before that swelling gets much worse, then it's been life-saving for your patient. A respiratory extremist due to disease. This is a patient that is way down the list of having a severe chronic respiratory disease. And if they have had an acute exacerbation of that, then you may consider going ahead and intubating them. The chances of them getting a lot better is not real good unless you go ahead and intubate. In the presence of a pneumothorax, a hemothorax, one of the thoraxes, and they have some severe respiratory distress, you may consider intubating them. You have to be very careful with these patients for one specific reason. Can you think of why? Yeah, if you overventilate them, that's whether you intubate them or not. One of the biggest problems you have is they've already got a hole in their lung, possibly, and you are vigorously and aggressively ventilating them, then you may do a lot of damage. So I said, I'm going to post this later, so it's going to be available for you. Okay, advantages of intubation, endotracheal intubation. It isolates the trachea so you can control that. With the dual lumen airways, there's always that risk of vomiting. There are other issues with that. But if you can isolate the trachea with intubation, that's the best way to do it. Once they're intubated, you should not have air coming out of the airway and going into the esophagus. So you should not have a lot of gastric distension. You don't have to worry about getting a good mask seal. If you've ever bagged a patient, that's very challenging sometimes on some patients to get a good mask seal. You can do bronchial tracheal suctioning once they're intubated, so that's real handy. And this last one, and in your textbook, it'll say it permits administration of medications. And technically, we can administer medications, some medications down the tube. However, it is not effective. They've not had any studies done that have shown that meds down the tube are really helpful. We have to double two to 2.5 times the normal medication dose to put it down the tube, and it's just not effective. But it is a route that's available to you. Does anybody know what the meds are you can put down the tube? Where's my writing pen? Somebody took it. I'll let y'all figure these out. Pretty good, pretty good. There might be one more, but I don't know what it is. Okay, disadvantages of ET. Disadvantages of intubation. It requires a lot of experience and training to be able to do this frequently, to be able to do it well. One of the problems we have is we're doing fewer and fewer intubations than we did in olden days, and we have, well, until recently, until we restructured this, back when we had paramedics and we had intermediates and then EMTs, I think that the intermediates could intubate. Yeah. They could intubate. So we had paramedics and intermediates that all were fighting for the tube. And since we're not tubing as many people as we used to, we're not getting as much experience. And particularly when you're in a low volume system, which around here it's probably less volume than some of the other larger areas. So you may not get the practice that you need. I worked in a service where if you didn't get an intubation a month, an average about 12 per year, the medical director would call you in, and you had to go a shift in the OR to get some tubes. So if you ask any of the practicing medics around here when's the last time they got a tube, they're probably going to say, oh, it's been a while. You might say, well, yesterday. But if you get a feel for how often they intubate, you'll see that it doesn't happen that frequently. It does require specialized equipment for the most part. There's some ways you can intubate, we'll talk about that, without using a laryngoscope, but you're always going to need a tube. You're always going to need a bag valve mask. So there's some equipment that's required. Now, here it says you must visualize the vocal cords. When we talk about doing a digital intubation, you'll do that using feeling with your hands, and you won't have to visualize the vocal cords. It's a real handy way. But generally speaking, we visualize the vocal cords. One of the problems when a patient is intubated, it's kind of like we were talking about breathing through a stoma, Their air is not moving through the nose, so it's not warmed, humidified, filtered, and all that kind of stuff. The air just comes from ambient air right into the lungs, so that can be very uncomfortable. Plus, it creates some other issues too, because the air's not being filtered. What's the problem I told you happens with patients who the air doesn't come through the nose? They create a lot of mucus. That's right, and then that's something we have to deal with, and I hate mucus. Okay, complications, and there are some complications that can occur because of intubation. If you have equipment malfunction, which one of the things that we will teach you is that when you open up your laryngoscope, you've got your blade on there, that you check to make sure the bulb is tight and bright. I'll say that, check that the light is tight and bright. I worked with a girl one day and she opened up her laryngoscope and she didn't check it. She put it in the patient's mouth, and before too long, the little bulb, which had rattled in the back of the ambulance for who knows how long, had unscrewed itself, and as soon as she opened it up, put it in the patient's mouth, the bulb dropped down her throat. And that didn't happen to me, but it can happen to you. So equipment malfunction, that would be bad. Teeth breakage and soft tissue laceration. Now once you start practicing this technique, this skill on the dummy, you'll see how easy it is to break the teeth. Furthermore, I've experienced this quite a few times where you have a patient that's already in poor health. They may be that way because they've had very poor living conditions, and you put your laryngoscope in there to lift up the jaw, and they have such poor dental health that those teeth are practically falling out before you even touch them. So that's a fair percentage of your patients, so you have to be very conscious of that. Hypoxia, how can a patient become hypoxic when you're trying to intubate them? Yeah, you take too long with that, you know, because pride stands in the way, and that really is probably the biggest thing. Your pride won't allow you to pull out and ventilate your patient, whereas you need to, 30 seconds is your limit. If you don't get that tube, you got to back up and ventilate your patient. But oftentimes, we don't have a good feel for time. If you've ever called 911, certainly the patients will tell you, they call 911, it sounds like they feel like it took you like 5 times longer to get there, right? But when you're trying to intubate, time flies. It's 30 seconds, before you've seen the vocal cords, much less, got your tube down there. So you've got to be very conscious of time so that your patient doesn't become hypoxic. Next is esophageal intubation. How many people breathe in their stomachs? Not too many. Frogs or somebody maybe, but we don't. And if you put that tube in the esophagus and you start ventilating the stomach, there's no air going to the patient, right, into the lungs. So that is a very real problem. And this is why I think it's so important you get some live intubations. You're just not going to really appreciate that practicing on these dummy heads. But you need to be aware of it in your brain. Endobronchial intubation. What is that? Somebody twist their hands. You've gone too deep, you've got a right stem intubation. That's what that means. And that happens also too. Tension pneumothorax, how does that occur? Yeah, you probably either ventilate without allowing that air to escape, or you put too much air in. We talked about this before. Some patients are born with a natural weak area in the lungs. And as long as they're just breathing normally, they're not going to put enough pressure in there to cause that to burst. However, once you start bagging a patient, you've got a tube right down in there. If they've got a weak area, there's a real good chance that you're going to pop a lung there. So you've got to be very careful with that. So when you're ventilating a patient, how do you know when to stop your ventilation? Do what? Nope. Chest rise. As soon as you see the chest rise, you stop. That doesn't mean it has to rise 6 inches before you stop. That means as soon as you see the chest moving, you're done. Okay, let's look at intubation. Now, we have equipment that you will use when you're doing a regular oral intubation. I'm going to show you some of this stuff. I'm making this noise right by the microphone. So, let's see what Nick gave me here. Okay, here you're going to see the handle, which, oh, there's one in here somewhere. Whoa. This is an adult handle. And we have, I don't think I have a pediatric handle in here. I'll never find it. The pediatric handle, there it is. is much smaller. But if you'll see, the top parts, the hooky part here, they're all the same. So it's really a matter of choice which one of these you use. You know, smaller women sometimes will use the pediatric blade the pediatric handle all the time. You know, guys probably prefer to use the big one all the time. But it doesn't matter if they're all checked out and this is all you have, then what are you going to use? Yeah, so it doesn't really matter what you use. Now blades, you see we've got two main groups of blades. We've got this straight blade, which is called what? A Miller, yeah. And the curved blade, which generally is a Macintosh. So if you think about that, I have an easy way to remember that. I've got a straight blade in here. This looks like an L, right? For Miller. This is curved like the C in Macintosh. Pretty cool, huh? It doesn't matter which one of these blades you use. You will probably develop a preference for one or the other. They tell me that 60% of men, only 60%, prefer the straight blade, and women generally prefer the curved blade. However, some work better in some situations and some in another situation. For example, for children, usually kids at least under 5 or 6, you're going to always use a straight blade. Does anybody know why? Do you remember me from EMT? You should know this. Because why? Well, their heads are big, so we need to poke it with a straight blade. I'm just teasing. Well, when you use this blade, the curved blade, you're not putting it under the epiglottis. You're putting it in the vallecula, which lifts the whole thing up. With pediatric patients, the epiglottis is very floppy. It doesn't have the tone that ours does. It hasn't practiced moving as much, I guess. But anyway, it's very floppy and it's large. Well, if you're using this to lift up in the vallecula, then that floppy old epiglottis doesn't get out of the way. So you'll need the straight blade to lift that epiglottis out of the way. So with pediatric patients, we always use a straight blade. All right. Now, when you put these things together, and this is a pet peeve of mine, when you put these things together, and it's a pet peeve because so many students mess this thing up. If you hold the handle in your left hand, you'll see it's got this little bar across here. Think of it like, gymnastics bar or something right here. You hold this in your other hand, you put them together, and it just snaps right on that hook. I can't tell you, I see students going like this and, this, and hold it up, got your hook, put it on. Once you put it on, you want to snap it open and look at that little light. Here is where you go. The light is tight and bright. If it's not real bright like this, you're not going to be able to see down your patient's throat. Even if it's well lit out here, that's going to make it even harder for you to see, and particularly in dim environments. So make sure it's tight and bright. Then take these things off. Now, when you open this up and you check it, if you're not ready to use it within 5 seconds, you need to close it and set it down. Once you use it, you intubate your patient, you pull this out of the mouth, it comes out like this, you close it because you want to preserve that battery because you want it to be there when you need it the next time. So always close that. That was easy, wasn't it? Told you that? Okay. Now here is the Macintosh blade. It doesn't look a whole lot like a Mac. But this is the vallecula right here that I was talking about. You will slide that tip into the vallecula, and when you lift that up, then it passively then will lift up the the epiglottis, and then you can see where you're going. So the difference between the Mac and the Miller, the Mac, you're going to place it in the vallecula. The Miller blade, you're actually placing the end of that tip under the epiglottis, and you're lifting the epiglottis. One of the problems with the Miller blade, it's very easy to get one that's too long, and before you know it, not only have you lifted the epiglottis, but you're down in here at the cricoid somewhere. So you don't want to get a blade that's too long. Anytime you're manipulating inside the patient's airway and you're jamming around, you run a great risk of causing soft tissue damage. Once they start bleeding in there, how easy is it going to be to see? Not too good. And now what do you got to do? got to stop and suction, yeah. So be very careful with that. Okay, the ET tubes. Let's see these babies. Now, they come in a variety of sizes. You can probably get them as little as like a 2. I think 2 is the smallest I've seen. And they'll go up to a 10. 10 is bigger, 2 is smaller. It's inverse of what we usually see with your IV catheters. So this is 6.5. So generally speaking, your adult patients, your male patients usually will take a little bit larger ET tube. And you're just going to have to look in the airway and kind of get a feel for what size tube you're going to need. And where's that little? Do y'all see the syringe that goes with this thing? Oh yeah, sorry. All right, I have a stylet. This is stylet. That's this thing here. They're quite handy. You want to use a stylet all the time. There's no reason not to. It provides form for your tube. I just pulled part of the end of it off. Provides form for your tube. It's going to make the intubation easier. So you want to do that. And it slides out like this. You can curve this thing any way you need it to be. And you can curve it once it's in the tube too. Now let me caution you with these stylets. Some of them will have this little stopper point, and if you poke it down in there, you'll do what I just did a minute ago. When I went to pull the stylet out, I pulled this whole end off like that, and you don't want to do that because now I can't bang my patient until I put this back in here. So don't poke it down in there, or you're not going to be able to get it off. What I like to do is decide how long I need that to be, and then I bend it over like that. So it doesn't risk going further down. It's also very easy to pull out. Okay, this, come on. This is the ET tube. This is a little balloon at the end of this where we're going to blow that up. What's the purpose of blowing this up? It's going to secure it in the patient's trachea. And what else is it going to do? It seals it so that you're not going to get anything coming or going, which, we're worried about aspiration more than anything else. I will tell you about this little balloon here. It's important, number one, that you always check it beforehand, because if it is, been compromised and you go to blow it up, and you blow it up and you go, oh, that works real good, and then it's got a hole in it and it backs itself down once you put it in the patient, that's a problem. Now, usually these will hold about 10 cc's. That does not mean that every patient gets 10 cc's. Because every patient is going to be a slightly different size. You do not want to inflate this to the point that it's this big old balloon thing that's damaging the patient's trachea. You don't want to do that. We have a little pilot balloon right here. And that's going to, because once this is inside the patient, you can't see that balloon, right? So this allows us to see how much pressure is in there. You want to put, once this is in the patient, you want to put in enough that it's firm, but, well, squishy still. You don't want it so that it's like cement in there. Like this is way too tight. If I can hit it like that and it feels really tight, it's way too tight. Probably want it, where there's a little bit of squish to it, because that soft tissue will be damaged. And if the patient makes it, that's bad for them. All right, what else do we have up here? The syringe. When you are testing this, which you're going to test before you ever put it in a patient, you want to blow up the balloon. So when you attach it, go ahead and have it pulled out like this. You put it in there and twist it a little bit, and you're going to fill this up, and you're going to check your big balloon. You want it to be capable of being fully inflated, even if you don't fully inflate it. And then you're going to back it out and deflate it, and make sure it's deflated. Now, see, mine still has a little bit of stuff in it. So I'm going to fully flatten it. It's going to make it much easier to go in the patient. So now once I've checked that, and I'm sure I have a stylet that's long enough, not too long, that kind of stuff. One thing, let me show you when you put this stylet in here. You do not want it to go as far as this little eye. We call this the Murphy's eye. So you want this to go long, but not past the Murphy's eye. Because if you stick this thing in, and it's going to easily come out the bottom or out the Murphy's eye. If you've got this end as the first thing that's introduced into your patient, what's going to happen to them? Yeah, you're going to lacerate them. And then you've got the blood issue again, right? So make sure that it doesn't go too far. Now, another thing you want to do is consider the shape of this. This will not go in your patient's through the glottis. So you're going to want to bend that. They used to tell me like a hockey stick or something like that. So you do kind of want it like this, because when the patient's laying down, what's going to be the tube on the top and what's going to be the tube on the bottom? Tube structure. Yeah, when you're laying on your back, the trachea is on top, just like now. The trachea is on the front, and the esophagus is behind it, right? So you want to hit the superior opening, so you're going to have to bend this. So you want to bend that. Is that everything on there? Yeah. I got this. Oh, yeah, next. So once you've tested all of your equipment and you're ready to insert this in the patient's airway, then you want to go ahead and attach this. And when you attach it, make sure it's open, because you're going to have to inflate that immediately. So have that fully extended. Now I'm ready to go. Once you've done this, you want to lay this down somewhere where you can get your hands on it. And that's very important. You need to know exactly where it is. So that means you are going to decide what area works best for you and put it in the same place all the time. As you've learned throughout this, that you've got to have a technique, so you're doing it the same way every time, or you're going to forget. For me, I always lay it to the right of my patient so I can pick it up. Tim lays his across the patient's neck. Whatever, I don't care. But I put it on the right side because that's where I'm going to grab it. And we'll talk about this more in a minute. Okay. You know what? On these packages, sometimes you have to look to see what the size is. This happens to be a 6.5. But if you look at this, right here is where it says 6.5, which to me is like mice type. Can't see that. So probably one of the things you're going to want to do is when you check off your bags in the morning, take your magic marker and write a 6.5 in big magic marker. Because when you've got a patient, bad patient, you've got to intubate them, the last thing you need to do is waste time trying to find, you know, where that says. So a little pre-planning is real helpful. This is a endotrawl tube or a ring tube, and he told me he put one in here. Oh. Yay for me. Let me show you this little device, because this is one of my favorite tubes. I don't know if your book talks about it or not. This is an endotrawl, or you'll hear me call it a ring tube. See, it's got this little ring right here up at the top. There are certain intubations where you want to be able to lift that tip. See, I'm pulling my little ring, it lifts the tip. I love that. These are very handy for nasal intubation. We'll talk about that in a few minutes. If you know you're probably going to have to nasally intubate a patient, I like to take mine and wrap it up and put it in my pocket so it's nice and warm and ready to go. So you have a nice shape when you go to do a nasal. But with this ring tube, as you're trying to hit your trachea, the glottis there, epiglottis, you can pull your little ring there, and then you can hit where you're going. So this is a ring tube. They're real handy. Usually with a ring tube, which usually are going to be used for nasal intubation, you want to keep those small. Usually a 7 or a 6.5. Okay. This is all stuff I've been over. Woohoo! Now, one thing about these, and I mentioned it, but I'm going to mention it one more time. All tubes are going to have an adapter like this, so it's going to fit your bag valve mask. So this is the same thing, not this particular tube, but if you have to intubate a patient with a stoma, you'll use this. You just cut the end off, and then, because you don't have to worry about inflating it, because that's not going to be an issue for you. You just need a little piece about like this to intubate them with. But this is your adapter, so make sure you don't pull that off by accident. All right. It's a 15mm adapter. Let's put my phone. All right, where did I set the little thing down? Is it under there somewhere? Oh, good, thanks. That's what I have y'all for. Already been through this, the assembly of this. Now, McGill forceps. I think I have some McGill forceps here. These are McGill forceps, and they come in a couple sizes. You can get, this will be an adult size. We have some that are half this size that we're going to use for pediatric patients. When would this be helpful? Yeah, if you've got a foreign body or airway obstruction of something that you can see, you don't want to be sticking this down patient throats. Not good. But I had a patient one time, a 1-year-old, 1.5-year-old, that had swallowed a bullet casing. You know, the little, you know, after you fire something, there's that little, what do you call that? A little shell. It's a little small copper shell about like this, but somebody had stepped on it, and so it was flat, and it was caught in the airway. So I was able to just like look in there and grab that and pull that thing right out. That was good, because that kid was about to die. FTD. Yeah, just like that. I practiced as a 5-year-old. I thought I had a picture of using that. Okay, so before you intubate a patient, and let me ask you this, do you all have the airway sheet, the intubation sheet, the check sheet? You should have that. If you have that, you might get that out. I probably should have brought some. I didn't know I was doing this lecture before yesterday. You have that. You want to start familiarizing yourself with that. You will check off on that sheet this semester, probably within a couple of weeks.
Ventilatory management?
Adult ventilatory management, thank you. Yeah, one of the problems that students miss on this sheet is they fail to hyperventilate the patient or pre-oxygenate. I should change that. We call it pre-oxygenate now. Because your patient's going to be going hopefully no more than 30 seconds without any air, but knowing some people out there, it may be much longer. So you always want to hyperventilate your patient or pre-oxygenate so that they've got some oxygen in there. We'll go through that sheet next week. I told you we're going to spend the whole time in the lab, so next week make sure you bring this sheet. Make sure next you're going to prepare your equipment. Just as I described to you, you're going to inflate the balloon, make sure that works. Make sure you've got a 10 cc syringe. You can use a larger syringe if you're following the guidelines and not overinflating that. Make sure you've got your stylet. What other equipment are you going to need? Yes, you'll need a BVM because you have to use that to ventilate your patient. Or certainly BSI, but to do your intubation. That's good though. Yeah, you've got this equipment. You've got a syringe. You've got the appropriate ET tube, right?
Need your handle and blade.
Yep. You're going to need your other equipment. You're going to need your handle. You're going to need to select the right blade that you're going to use. What else are you going to need?
Securement device.
Yeah, you're going to have something to secure the device with. What else?
Sort of capnography or...
Yeah, something to check a CO2 monitor of some sort. So on some of you, when you're working in the field, you may have access to a capnographer that is attached to your monitor. Do y'all have those? Those are real handy. If you don't have that, you're going to use something like this, a little manual one. Anybody have any idea what color this should be if you're in the trachea and you're ventilating your patient well? Yellow? You're sure? Who told you that? I've just memorized that. Good. That's right. Yellow means yes. So it's going to change colors. It's going to change from yellow to purple. It's going to fade back and forth as you've got carbon dioxide passing it or if you've got air passing it. So it's going to change colors. These are one use only, and they're not going to last forever. If you're bagging your patient from here to Birmingham, you may have to change this out if you don't have a regular capnographer on your monitor. You may have to change this out. Once this has been opened, like out of the bag, you know, unsealed, it might last for an hour or two. After that, it's been exposed to the air too long and the pigment won't work. So, what else? So you're preparing your equipment. Now, you may have somebody apply Selleck's maneuver when you're trying to start your intubation. And the Selleck's maneuver does what for you? Yeah, it's cricoid pressure, and why do we use that? Close. Opens is probably not the best word. It lines it up. Yeah, when you put that pressure right down here, it's moving the trachea down. It's moving the glottic opening down so that you can better visualize it. They used to tell us to do it even when we're bagging a patient because it prevented any movement of fluids from the stomach. They found that that really is not all that effective, and oftentimes we do it so hard that we damage the airway and the esophagus. But we use it mainly for laryngoscopy to bring the vocal cords down in line so we can see them, so we can visualize them better. Whether you use that or not, it doesn't matter. Okay, visualize the, so once you're sure that you're ready to go, you've pre-oxygenated your patient, you've laid out all of your equipment, now you're ready to put your blade down your patient's throat so you can see. Your goal is to visualize the vocal cords, and it's not easy to do. But I will tell you this, and this is like the Curry golden rule. Once you see those vocal cords, do not take your eyes off those vocal cords. Once you see them, it's kind of like, you know, you're driving down the road, you see something on the side of the road, you're like this, you turn your head, what else turns? Your car. You're just like this. So once you visualize those vocal cords, as soon as you move to pick up your tube or pick up equipment or whatever you need, you've lost your sight. You've moved your hands. The vocal cords are gone. So now you've got to look back and find them again. So once you see them, you've got to hold on to them with your eyes. Okay, this is a picture of some vocal cords. Is this person breathing or not? No, they're not breathing currently because the vocal cords are tight and closed. Now, the epiglottis, they have that up and out of the way too. Or they might be whistling or something, they might be closed. But this is some closed vocal cords. I think I have a picture of some open ones. Yeah, that's open. The glottis is open. This is the epiglottis up here. So your Miller blade will be going where? It's going to be right here. It's going to be lifting up that epiglottis. Where is the curved blade going to be?
Above.
Yeah, it's going to be above that and lifting. When it lifts, the epiglottis kind of comes straight, you hope, but in a child it's going to flop down, right?
So if the vocal cords are shut, are you going to be able to pass your, like, be able to thread the tube? And
Yeah,
open them,
they
or?
usually stay open, generally speaking. You should not, I've never had a circumstance where they were closed and I couldn't get in. That was a good question. What if they are? Just poke it in there. So once you've passed, you're going to take your tube, where's my tube, and you're going to visualize this balloon passing through the vocal cords. And then once they've passed through, and this little black line, I'm telling you, you can't see inside, but that's really about where you're going to stop. You're going to pass this through the cords and just give it a little bit, maybe a half an inch or so, and you stop. So this is just going just past the vocal cords, and then you stop. You don't want it any further than that. Okay, so you've put that just past the vocal cords. I don't like these. Just past the vocal cords. Now, you're going to pull your laryngoscope out. You're going to close it and set it down. But you don't need it anymore. We've already passed this. Next thing, you're going to hold on to this like it's made of gold. So you're going to hold on to this. The next thing you're going to do is remove your stylet. Don't need that anymore. You're going to inflate your cuff. And how much air are you going to put in there?
Until the blue bubble.
Until the blue bubble is taut but not hard. Not rock hard, just pleasantly plump. How's that? And then you got to pull this immediately off. Because what's going to happen, you've inflated this. If you leave this, that's going to back out and you've lost your balloon. So you got to make sure that you immediately, as soon as you do this, you take it off. But while you're taking this off, you're also holding on to this tube. So this is going to be the way you're going to do it. You're holding the tube, come back. You're holding the tube. You've inflated. Bring it up to this hand and pull that thing off and set it down. Okay, now what's next? Got to ventilate. So you're going to put your bag valve mask on here without the mask, and you're going to ventilate. When you're ventilating, somebody else should be auscultating. Or they're going to ventilate and you're going to auscultate. Where are you going to auscultate first? All right, where are your choices? Lungs and the epigastric. So where are you going to listen first? Who thinks it's lungs? Nobody thinks it's lungs? Doesn't that make sense? We're ventilating the lungs. Who wants to listen to the lungs first? Y'all are chicken. Chicken, chicken, chicken. Who wants to auscultate the epigastric first? Okay, if you raise your hand now, you have to tell me why. Well, why?
Because you want to make sure you're not in the stomach, so you get one.
Exactly. If I'm in the stomach, I want to know early before I put 4 or 5 or 6 breaths in the stomach, because you know, any patient you intubate, what have they just eaten? Pizza with ketchup on it, with lots of onions and cheesy fries, and they've drunk a couple beers, something really nasty. So as soon as you put all that air in the stomach, what's going to happen to Mr. Johnny? Oh man, he's going to puke like crazy. So you might have the airway secure, but they still puking on you all around the tube. So you want to auscultate over the epigastrum first, and then all 4 quadrants. I say quadrants even though we have more than 4. You're going to listen high, you're going to listen low. You should hear air moving while they're ventilating. All right. Now you're also going to have to put your carbon dioxide monitor. This one is real handy. So you can either put this on at the time you're doing your first ventilation, which I would suggest, or you can put it on later, but I suggest you do it then, because how many times do you have to move air through here before you have an accurate, dependable reading?
3, 6, 8.
Yeah, about 6 times. So you're going to have to ventilate your patient 6 times before you can trust what this monitor says. And if it's purple, that's not good. What are you going to do? Reposition. What does that mean? If this thing is purple, you've been bagging 20 times and it's purple. What does that mean? Well, you're probably not in the airway. However, if you have auscultated and you see chest rise, if that chest is rising, I'm in the airway. So if you have visualized the movement of that tube through the cords, where are you? You're in the airway. As long as you haven't dislodged that, which happens sometimes too. So you've got to keep that in the back of your mind. All right, so after you're sure you're in the right place, you've confirmed it with at least 2 different methods. That's a requirement by American Heart. You have to confirm that at least 2 different ways. You're going to secure the tube. Now this is, must be an old slide. They want you to secure the tube with a commercially available tube holder, of which this thing is one. You've probably seen these. Yeah. And these will fit the combi tube. I've seen them. You got to do a little bit of work to get it in there. But this also has a bite block, which is real handy. Here they put OPA in to use as a bite block. You don't want your patient biting your tube in two. That's never good. All right. How are we doing so far? Is it time for a break? Yeah, let me see what time it is. Let me see my watch. Oh, what time are we starting here? 9:45? We're probably starting here at 9:45. Okay, y'all take a break. Come back in about 10 minutes. Is that okay? And we will continue on here. We'll start moving quicker.
Pause your recording.
Oh.